right. So good morning, everyone. I know some of you know me. I'm Dr. Grace McComsey. I'm the principal investigator of the CTSC, which stands for Clinical and Translational Science Collaborative of Cleveland. So I want to welcome you on behalf of the CTSC and thank you for joining us. I know everybody's busy, but I think this is an important program. It's the fourth and final challenge in our second annual Health Equity Challenge series. The CTSC's Women's Health Equity Unmeeting, and women's health is becoming, I would say, more and more important. Although some areas, debated by some people, but I think it's very important for everybody to get together and discuss it. So we're delighted to co-present this year's program with the Michigan Institute for Clinical and Health Research at the University of Michigan. Before we begin, I just want to tell you a little bit about what the CTSC stands for people who don't know who we are. So the CTSC of Northern Ohio is a collaborative among Case Western Reserve University and its affiliated hospital systems. So that would be Cleveland Clinic, Metro Health, University Hospitals of Cleveland, and the Cleveland VA. We added recently 2 new partners, University of Toledo and NeoMed. So all these 7 institutions constitute the Cleveland or CTSC of Northern Ohio. We used to call it CTSC of Cleveland, but because of Toledo and NeoMed, we expanded to Northern Ohio. So what we do is we inspire to be a catalyst for high quality clinical and translational research. And we want to do it both locally and regionally, but also nationally. We want to change the culture and the environment of research and share resources, expertise, and streamline the research process. We want to move translational research from the bench, from the lab to the bedside, but even more importantly, to the community, because any research that doesn't get to change people's lives in the community is, in my opinion, a failed research that's meaningless. So we can't do this work without you. And as we approach the first year of our grant, it's a 7-year grant. Can't believe actually the first year is almost over. We're focusing more and more on including the community in the process of clinical and translational research in our collaborative. Our theme in the application when we submitted it was focused around health inequities in our area and improving or closing the gap on health disparities. So we do want to do that. We have started very exciting, I would say, collaborations with community organizations, and we still have a lot more work.
I'm not really paying attention.
Without further ado, I'd like to introduce you to the principal investigator for this unmeeting, Dr. Rachel Pope, who's assistant professor of obstetrics and gynecology at University Hospitals, very interested in women's health, as you'll see. So Dr. Pope, the floor is yours, and thank you for doing this. Dr. Pope is with us. Let's see. And see everyone. Jalise, do you know if Dr. Pope joined? Or?
I did see her name earlier. Hello. Can you hear me? Yes, perfect. Oh. Hi, Dr. Pope. Okay. Sorry about that. Hi, everybody. I'm so happy to be here participating in the Health Equity Unmeeting. This is a first for me, but this is definitely a topic that is close to my heart. And as we're going to go through some very exciting lectures today, it's unfortunate, but it will be very apparent how much inequity there is for women's health. It's exciting to see kind of what is happening throughout the country. More attention is coming towards women's health. You know, the First Lady is starting a large initiative to start large funding for an ongoing period of time to really draw people's attention to women's health inequities and to fund more research. The NIH is constantly trying to fund more research, but you know, it's been a long time coming and we have a lot of work to catch up. So exciting that we're having this conversation today. And do you have control of the slides there? Okay, just to go through kind of the agenda. So we are going to start with our 4x4 presentations. So if you haven't seen this before, each person is supposed to stick to about 4 minutes and have only 4 slides to cover their topic of interest. And so it's a great way to kind of get these bite-sized presentations, learn something new. The topics are going to be slightly different, you know, but you're going to get a lot out of them. And then we'll have a breakout session at 10:30. And then we'll have our next set of 4x4 presentations at 11:30 with breakout at 11:50. And then we'll kind of go through our synthesis of what we're taking away from the whole day. The whole point of an unmeeting is that there's not a keynote speaker. There's not one main person. We do not have the rules and the structure of a traditional conference. We really want all of you who are attending to drive the topics and drive these discussions around the theme of women's health and equity. We are hoping this will be interactive. So we'll have times where, you know, you're in your small group or you're in the main group and we're hearing from each of you. We want to hear about, you know, your thoughts. You all come from unique backgrounds and have a lot to add. We want this to be an opportunity for collaboration. We've got people from all over, including our partners in Michigan. So this is a great way to kind of put our heads together and think of how we can make improvements, right? So the research is just the beginning to define what the problems are, but then we need a team of people who are going to do something about those issues. And that's why we're so excited to hear from all of you today. I love this. To break the rules, you must first master them. So you dictate the conference. There are no wrong questions or answers. We want all voices to be heard. You know, we're not going to pick on you or call you out, but we really want to give you all the opportunity to be able to voice what's on your mind. Again, it's about collaboration, not promotion. We're not trying to promote any particular person or, you know, company or institution. It's really about just all putting in our minds and brainstorming today. We do have some scribes with us. Veronica Dahlberg, who's the executive director of HOLA, Ohio. Hello. We have Zena Hempstead, who's the manager of the Administration and Research Health Equity at the CTSC here in Cleveland. She should be on there. Hello as well. Clara Palfrey is our evaluation director at the CTSC. Hi, Clara. Mackenzie Ritter is our assistant director of the Research Education and Training Program at the CTSC. Hi, Mackenzie. And we have some catalysts. So our catalysts are Deborah Bruno from University Hospitals, Shelby Domino, manager of Research Integration and Education at UH, PJ Kimmel, who's the project lead for Better Health Partnership, and Mary Lee Santiago, the director of Transformative Knowledge and Education at the Metro Health Institute for Hope. So welcome everyone, and that's who's who. In terms of housekeeping, if you have questions, message Jaleese through like the direct message if you can. And then we will have a post-event survey after the unmeeting. We'll send this link out to you. Again, you don't have to copy this link right now. And we would love to stay in touch with you after this. So please be aware of our website and the email for the CTSC and the way that you can follow us on X, on Instagram, on YouTube. We really try to continue these conversations. We don't want this, you know, I'm sure there's going to be a lot of really great stuff that comes out from today, and we don't want things to just stop or drop here. We want this to be a continued conversation with more ideas and more sort of community interventions on an ongoing basis. this meeting will be recorded. And if you want to watch it, or if there's any part that you have to miss, throughout the day, you can go to the YouTube channel to catch back up. All right, so I guess with that, we're going to jump into our 4x4 presentations. Am I able to share my screen? I just made a couple updates to my slides. I'm going to kick that off for everybody. Okay,
Absolutely.
cool. Thank you so much. So I'll do this. So this is a little bit of a non-traditional topic. Let me see if I can just give you the slide view. Let's see here. Here it is way at the bottom. Sorry about that. Okay, can everyone see my slides okay? Okay, so I am a gynecologist. Thanks for the thumbs up. I'm a gynecologist at University Hospitals. I'm in the Urology Institute. The reason being that they started a division for female sexual health about 4 years ago now, since I've been there, with the point to really draw attention to this area. And what has been fascinating for me, especially as a person with a background in research and in public health, is that so much of what my patients come in to talk to me about comes from social media. And it has gotten me to the point of, really becoming somebody who's putting information out on social media myself, even though this is very awkward and not natural for me. And it's way easier for me to write a paper and submit that for publication. But I've come to realize that now I've got to kind of jump in with all of these other individuals who are out there on social media because of the misinformation and the miseducation that is happening. So why is this happening? There is a real void within women's health, and especially in sexual function or dysfunction, especially around menopause, around really anything that is intimate and has a cultural taboo. And so much of women's sexuality and reproductive health is still slightly taboo to talk about openly. If you think about, what kind of dinner conversations you'd be comfortable having with your family, it's not usually about intimacy. It's not usually about pelvic pain. And that's just because of our North American culture. Then when you do have a problem and you want to talk to a healthcare provider, it's kind of hard to figure out who you can speak to about it. Your gynecologist might be focused on screening you for cervical cancer and making sure that your pap smears are up to date, making sure that all of these really important sort of life or death issues are being covered. They might be focused on helping you try to conceive or talk about contraception so you don't unintentionally conceive. If you're going to see your primary care physician, they might be checking your cholesterol, your lipids, your blood pressure. There are so many other things that physicians and advanced care providers who are taking care of you are thinking about and trying to complete in a very short appointment, when they've got a very busy schedule with lots of patients. And so they tend to not ask you questions that are maybe about quality of life or maybe about something like sexual dysfunction unless they suspect that there's a problem. However, research has shown us that women tend to not want to volunteer this information. They're actually waiting for their healthcare provider to ask them. And so you've got this set up from both sides where then the conversations are just not happening. So then what happens instead is people look to social media. I've in clinic this morning, and I've already had several patients say I was following so-and-so on TikTok, and it's astounding. Studies have been done to see where women are looking for menopause information, and TikTok is the #1 place. Well, I've had patients tell me, I'm not sure if who I saw talking was a healthcare professional, but they said I should use this hormone and not this one. And, thank goodness she's coming in and asking me about it. But lots of people are finding alternative sources and alternative ways to access the treatments and the things that they're finding online that sometimes are financially backed or financially motivated and not necessarily evidence-based or health motivated. You've got things on TV and on the internet, like Gwyneth Paltrow's companies, that's all about sexual enhancement, not necessarily evidence-based. We do have people in the private sector who unfortunately might be more financially motivated, not to say that everyone in the private sector is bad. There's, lots of wonderful practitioners, but there are financial incentives behind running a business. And when you see that there's a void and women are willing to pay thousands of dollars to have a hormone panel done or to have a hormone test done because they saw someone talk about it on TV or on Instagram, there is this real unfortunate opportunity for women to be taken advantage of. And this is why I think academic medicine needs to get involved. We do care for the best health outcomes for our patients. We've got lots of evidence. We have people who want to research this and weigh the pros and cons and be able to help women live their best lives, help with pain, help with low desire or arousal or orgasm issues without necessarily taking advantage in terms of trying to make money, and also making sure that things have been well researched so they could say there's good evidence or there's not good evidence for this. So this is what's really motivated me. I started a website that has blogs. I also have a podcast where I've brought people on to talk about these issues, and I try to find specialists. So Dr. Jill Kraft, for example, is a specialist of vulvar disorders that I had on to talk about lichen sclerosus. I've had colleagues from UH, Anna Myers and Jean Marino, who are both women's health and urology experts, respectively, and they've been very wonderful to kind of approach different topics. We don't all have time for this in academic medicine, but I think it's something that we have to kind of face, that our patients are getting information somewhere. And if we don't put out good information, then there's a good chance they're going to find some pretty faulty stuff. And so that is the end of my 4x4. And I'd love to pass on to the next person.
All right, Tanisha, you're up.
I'm sorry, Jalise, I didn't have my slides ready. I'm ready now, though. I apologize. Hello, everyone. My name is Tanisha Gaines. I am co-founder and director of operations for the Village of Healing and the Village of Healing Center. And I am going to discuss bridging the health disparities for Black families in general. So what we do here at the Village of Healing Center, we are a community development organization, and we have a new approach to community wellness. And we're focusing on healing and empowering individuals while we work to eliminate those social determinants of health and decrease health disparities through our programming, our advocacy, and our collaboration. And by doing that, what we do is we make sure we are centering Black women's voices and their experiences. We are challenging those existing inequities that we all know exist, and we're creating pathways for that transformative change in healthcare. And these are just some of the services that we currently offer at our center. So we offer our primary care, women, OBGYN, and our mental health. So when we talk about transforming healthcare outcomes for Black families, I'm pretty sure all of us on this call have heard all of the statistics and the data before, so we don't have to go into that. But just being able to discuss how Black families and women are experience those health disparities. And we have higher rates of chronic diseases, maternal mortality, infant mortality, and those mental health challenges. And we also want to make sure people understand that when we talk about those health disparities among Black families, it doesn't matter what that socioeconomic status looks like. A lot of times when we hear about social determinants of health, we always hear, and it's put into the aspect of it's poor Black families or poor Black women. But we want to make sure that we are changing that narrative and that we understand that no matter what your socioeconomic status is, you're still going to experience these health disparities within either yourself or your family. And what we do here at the Village of Healing, we want to make sure that we are following the evidence, because we know that evidence states when you have a provider that looks like you and that takes care of you, your disparities are decreased. You are more likely to follow the plan of your medical care. So we are Black providers, and we're focused on Black families and Black women here in our center. And we use that family-centered approach, right? So we want to make sure that we acknowledge that there is an issue, we address that issue, and we put an action steps in place to resolve those issues that we have here in our community and in our as a whole. Another way we are doing that is with our pediatric postpartum model. So what that looks like, we have women, here that have, women have babies. So as my child would say, olden days, you have your postpartum appointment, and then your child has their well child appointment, but those are at two different places at two different times. And we know we have an issue with as women, and Black women in general, we have to get back to work. So I'm not going to go to my postpartum appointment if I have to miss work. I'm going to make sure I take my child to that well child visit. So what we're going to start doing is we're going to have that mom and baby appointment in the same room at the same time on the same day with the same provider, right? So what that looks like is you're coming in for those 8 to 10 well child visits, but I physically get to see the mom in that room with the family, with the midwife or the family med doc, and she's getting her blood pressure checked. She's getting a depression screen. So we're making sure that we are taking care of that mom as well in that first year of life. And we're not just saying, oh, we'll see you back in 6 weeks and then that's it. So that is going to help decrease those maternal mortality and morbidity rates that we know affect Black women more frequently than white women. And also what we look at is, how we're advancing equity for future generations. We want to make sure that, we are the experts, right? Because we are Black women and we are the experts in our field. And so for us, that looks like expansion. So expanding to a second site and making sure we're caring for other parts of the community who have a transportation barrier and can't get to us. Having that community engagement, not going into a community and saying, hey, we're going to do A, B, and C. No, we're speaking to the community. We're speaking to them and asking them, what do you need? What does healthcare look like for you? What are your barriers? So making sure we're involving the community that we are going into and not going in with those initiatives, and making sure we're bringing those community members to the table and speaking with them and getting the knowledge from them before we implement anything. Also doing research, making sure we are currently working with Cleveland State to do research, because we know that people will say, what does the evidence say? We know that the evidence states, like I said, if you have a provider that looks like you, your disparities are decreased. So we are doing research, having advocacy and advocating for our patients, making sure our patients know how to advocate for themselves when they have to step into hospital systems. And collaborations, making sure we are collaborating with local grassroots, boots on the ground organizations that we know have the results, have the evidence, are decreasing the disparities, and making sure we're working together and not against each other, that we're coming together. We are making sure we are not siloed, and we're making sure we're creating this collaboration where we're taking care of not only mom, but the whole family, and everyone in that family is not just, surviving, they are thriving. So that is all I have, and thank you very much.
Thank you, Tanisha. Dr. Crow?
Thank you so much. That was really good.
Thanks, Dr. Pope.
All right, sorry, I was muted. Can everybody see the full screen version of my presentation?
Yes, it looks.
Okay, thank you. Today I'm Dr. David Crow. I serve as the chairman of the Department of Dermatology for Metro Health Systems. Our patient population is quite ethnically and culturally diverse compared to other institutions in the city, and which allows for a unique opportunity to start a specialty clinic devoted to the care of skin of color. I'm going to call back to some of the things that Tanisha said in her presentation because some of it applies to what I'm talking about, certainly. So a skin of color clinic traditionally refers to care of people with Fitzpatrick skin type 4 through 6, which generally equates to kind of these skin tones on this graph, and it usually includes people of Latin and Hispanic descent, African descent, and Indian heritage, among others. We know from our institutional data that the percentage of African American patients seen in our specialty clinic, in our dermatology clinic, is lower than that seen in other medical specialties at Metro Health, which indicates an access gap. So that's part of the reason why we wanted to start this clinic. Now, the idea of having a skin of color center is not unique to our institution, and several others exist across the country, some of which are composed of multiple physician providers. They have robust sources of funding, and they have extensive research platforms. We're kind of similar to this group because right now we have none of those perks, although I really have hope for this in the future. My focus at this point is to increase access, create a safe space in which patients with skin of color can draw comfort in the knowledge that they will see a board-certified dermatologist with an interest in treating darker skin types. My first year leading the clinic has not been without challenges, although I've settled into a gentle cadence of seeing patients every Monday morning at our main campus dermatology clinic. I've noticed some trends. There, about 75% of the patients identify as women, and 97% identify as African American, and most present with inflammatory skin disease and hair loss, rather than for routine screening examinations. These visits generally take more time. There's more patient education and more need to build rapport. Tanisha mentioned earlier, and it's well known that patients want to be seen by someone who looks like them. And there is a distinct lack of African American physician representation in the dermatology profession. To their credit, all patients have been willing to give me a chance and allow me to prove my knowledge. Although, sometimes it's there's some disappointment when I walk in the door. So there's broader horizons in mind when you start a skin of color center. Beyond the primary goals, which I've already discussed, providing access, improving public health, building trust, providing unique services, there's downstream benefits as well. Now, my first love is education, and education around the diagnosis and treatment of skin of color for young physicians is across the country is really disappointing. At Metro Health, we have been taking strides toward inclusion of skin of color education materials at the medical school and resident level, and we've advocated for more diverse representation of skin disease in textbooks. There's also much more research needed in supportive treatments for conditions like hidradenitis suppurativa and types of scarring hair loss, which are more common in African Americans. So some research ideas that I've had include investigating novel surgical techniques for hidradenitis suppurativa, which is really a very difficult condition to treat that occurs more often in skin of color. We've started to perform outpatient surgical techniques for hidradenitis in conjunction with the multicultural dermatology clinic, which has been shown to be a low-risk option to improve chronic pain and drainage of wounds. So other ideas we've had is the use of platelet-rich plasma as a add-on treatment for scarring hair loss, which occurs predominantly in African American women. And we also want to use dermatoscopic monitoring, which is basically a handheld magnifying device that gets you about 10 times magnification. You use these devices to follow hair follicle status during and during treatment as a prognostic marker and outcome measure. You can see a up close image of a dermatoscopic image of the scalp. So these ideas only scratch the surface of what is possible when consolidating individuals with similar characteristics and medical problems into a specialty clinic. So it's daunting for someone who's a novice in the field of research, as I am. So obviously I'm going to need a lot of help. Another hidden gem of starting this clinic that I believe is that I believe that talented people who believe in the mission to close gaps in dermatologic care will join me in building an infrastructure far beyond these humble beginnings. So thank you very much for your time today.
Thank you, Dr. Crow.
Hey, can everybody see my slides?
Yes, thank you.
Great, thanks. Yeah, so thank you so much for the invitation. My name is Justin Colsino. I'm a associate professor in the School of Public Health at the University of Michigan, and my lab is focused on prevention and really understanding the drivers of diseases like breast cancer and how environmental factors may be promoting the disparities that we see. And we know that these disparities are profound. Probably this is not a surprise to folks in this audience, but these are data from the Centers of Disease Control looking at breast cancer mortality based on individual self-reported race or ethnicity. And we can see really, really striking disparities. I think this is one of the most important challenges in cancer and public health, where you can see, for example, disparities between Black women and Asian Pacific Islander women, about 2.7-fold differences in the rate of breast cancer mortality. And so many folks have been studying different etiological drivers and sociological and systemic drivers of these disparities, but I'm an environmental health scientist, and we're really focused on understanding how our environment might impact breast cancer and breast cancer disparities. Because we know that chemical exposures themselves, things that are coming into our bodies from the environment, are not distributed equally. We know that where we work matters on what gets into our bodies, right? You can think about these folks on the top left there, they're working at a job site, they're exposed to dust, they're exposed to noise. We can contrast that with somebody that works on a farm, right? They might be exposed to pesticides, they might be exposed to fertilizers. That's already going to be a major driver of somebody's chemical exposures and what's getting into their bodies. We know that where we live is a huge driver of these exposures, right? This picture here is the in our neck of the woods in Southeast Michigan, the Marathon oil refinery in Detroit. We can see that there's this oil refinery that's belching out all of this air pollution into this community, and right in front of that refinery is a playground, right? There's like kids that are growing up in this environment. This isn't something, of course, that's unique to Southeast Michigan. I'm from Texas before I moved up to U of M. And down here on the bottom right, this is a picture from Cesar Chavez High School, right? Where there's like folks playing football. Right in the backdrop there is this like refinery or this chemical plant that's like belching air pollution. So we know that the community we live in very much matters. It's the concept of environmental justice, which I think probably most folks in this on this call are familiar with. We also know that the water we drink, right, can really impact our chemical exposures. These are pictures of the contaminated water from our neighbors up in Flint through the Flint water crisis. And unfortunately, this is not an issue that's unique to Flint, right? Many communities across the state of Michigan, across the US, across the world are dealing with contamination in their water. We know that what we eat really matters with respect to our chemical exposures, and then what we're using in our households and our bodies on a daily basis. Thinking about the products, the cleaning products that we're using, our makeup and personal care products. All of these are impacting our health. Maybe some of y'all have heard about this term, the environmental injustice of beauty, where westernized beauty standards are really driving exposure to hazardous materials and things like makeup and hair relaxers and hair straighteners that we are now starting to see are associated with an individual's cancer risk. And this is all in the backdrop of this broad range of chemical exposures that we can be encountering on a daily basis. Many folks don't know, but there's around 100,000 chemicals on the market. Very few of them had been tested for safety. We end up being the guinea pigs for a lot of these. So this is what my lab is focusing on, is understanding what are people exposed to, and could those exposures be promoting the diseases like breast cancer? And so how we do this is we know that exposures are coming in from many different areas. We can think about, you know, the plastics from our environment and pesticides and heavy metals, air pollution, things from our diet. They're going to be getting into our bodies. And what we do as environmental health scientists is try to understand what chemicals are in our bodies at what levels, and are there differences in chemical exposures, say by demographic groups. And to do this, we use a technique we call exposure biomonitoring, where we recruit individuals into a study, and then we can collect what we call biospecimens from them. It's usually going to be a urine sample or a blood sample, and then we can measure different chemicals in those samples. And what our lab is seeing when we look across tens of thousands of women in the US is that we can see that Black women are disproportionately exposed to many chemicals. And again, this is independent of socioeconomic status. Like we were hearing before, these are compounds from personal care products like parabens and phthalates, things like pesticides, air pollution, heavy metals, and then some of these forever chemicals that build up in our bodies like PCBs and PFAS. With some of these chemicals higher, 300% higher in non-Hispanic Black women than the rest of US women. And so what my lab does is really try to understand, how does this work? How do these chemical exposures impact breast cancer? Really thinking across how breast cancers form. And so that's what's being depicted on this cartoon here. These are the different stages of breast cancer, as like cells will start to grow in the breast duct and then invade, and then spread to different organs, right? We're trying to understand, how do environmental exposures, especially these disproportionate exposures, impact these diseases? And so I'm a lab scientist. So we do a lot of our work in cells in a dish, where we can expose these cells to those chemicals where we see that Black women are disproportionately exposed. We can do experiments with mice, but we really try to keep this anchored in the human experience. And so we use a technique called epidemiology, where we're looking across large scale populations and developing large scale cohorts to really understand these links between the environment and cancer. We have one such study that I'd be happy to talk about in more detail called My Cares, where we're recruiting individuals across Michigan, looking to see the impacts of environmental injustice on cancer. And then we try to like bring these two concepts together, so that we can really start to interrogate which chemicals might be the ones that are driving aggressive breast cancers, because these are things we can then design prevention interventions around, and potentially policy interventions to reduce exposures across the whole population. So I will pause there.
Thank you so much. All right, so everyone should see that the breakout rooms are open. Participants, please select a breakout room that aligns with the topic that you find most interesting. And 4x4 presenters, please join the breakout room that aligns with your topic.
Yeah. So. Have many resources out there.
All right, it looks like most people are back in the main room. If we could have one person report out from each breakout room, we'll start with Miss Education and Women's Health.
Shalise, do you want me to post the notes in the chat?
No, we'll save those for this. This is later. Thank you, though.
Maybe Shelby, do you want to give the summary?
Yeah, sorry. I was trying to save the chat from our meeting, and so I got like all discombobulated. Anyways, sorry about that, guys. But yeah, it was a really cool, interesting chat. Had a lot of different people come in talking about how the pros and cons of social media. I think that was like the interesting thing is that, Dr. Pope presented it as there's a lot of misinformation coming from social media with the medical field, but then some people were saying like, oh, well, the social media actually like brings community together when you do have like a certain medical condition that is rare. So it's kind of interesting to hear the pros and cons of things. And then, kind of going about how some people will say, let's not do this medical procedure or this certain type of contraceptive because everyone on social media said it was terrible and I had so much pain and the risk and the side effects and da da da. But, actually going to the doctor would be like a different story type of thing where, they're actually there to talk about like the risk and benefits. And sometimes with one bad cookie in the bunch, it ruins it for the whole thing. So it's like we definitely were kind of like diving into a lot of that as well, where it's just like it's a shame that sometimes with some of these medical procedures, you get one person who just blows it up and becomes this huge celebrity and just says like, oh, it's like, the worst thing ever. And then like everyone else comes to their doctor and they're like, oh my gosh, I saw this person. And so, it was definitely interesting. And then, it was great too, because we were talking about like the marketing research behind it all, how it's like, okay, we get rid of TikTok, what's going to be the next thing? Is it just, because like, we were talking about how Vine was the original TikTok. And so it was kind of cool to kind of hear the transition with everything and the overall discussion. So it was good.
All right, if we could have someone from Health Disparities in Black Families.
I took lots of notes on it. I'm happy to go through. We talked about, I think the question really was how do the higher rates of disparities affect Black women's families? And Tanisha talked about maternal mortality. It affects Black women regardless of their socioeconomic status. So this is not an economy related thing. And that rate of maternal mortality is 6 to 7 times more likely to suffer in the first year postpartum than women who are white. We talked about why Black women are thought to live more stressful lives. And it has to do with the microaggressions that appear to be systemic. It affects the whole family because really the women are the ones who run the household. Let's see, Tanisha was asked about getting out into the community, and they do a lot of marketing at the Village of Healing. They attend various health fairs. They refer their patients to other Black providers elsewhere in the community. And then there was a question about in those visits with both the mom and the baby being seen at the same time. There are 2 health professionals in the room at the same time. The midwife is seeing the mom and the nurse practitioner usually is seeing the baby in those well-care visits. They do use community health workers, and they also, every patient or individual that walks through their door fills out a socioeconomic status questionnaire so that the community health workers then can use that as a referral to go out into the community for those individuals. They are or have been connected in the past with the CWRU's collaborative practice class, where student teams work with community organizations all year long on challenges that those organizations have. Another thing that came up with this is a term I didn't know, weathering. I'm assuming it's spelled like weather, outdoors, rain, that sort of thing, weathering, and it's referring to the cortisol levels that many Black women are perpetually in the fight or flight mode, and both in the workplace and in the community, and also the quality of food, the health care they get, hypertension, diabetes, cancer, environmental racism, poor air quality, all of these things disproportionately affect Black women. And so they live more stressful lives. The model of Village of Healing works because they are independent. I found this really interesting. Tanisha has worked in hospitals before, and the hospitals have, as we know, all hospitals have tons and tons of rules and policies and things that basically made it really hard to do her job and to provide for her Black patients. And so the Village of Healing found that really you have to be outside a hospital to do what they do, and to be able to advocate for their patients. They are in Euclid now. They are moving into the city of Cleveland, and some places are very focused on reducing disparities in those areas. And the zip code 44128 has the highest infant mortality in all of Cuyahoga County, probably in all of Ohio, I would guess. They are not an FQHC. Again, too many rules, just like hospitals have. But they do work with FQHCs and with hospitals because they need those relationships in order to function in today's society. They became a community organization in 2019. They weren't a health center at first, and then they started with maternal mental health program and mentored those moms with various mental challenges, and used all kinds of things to do outreach into the community, text, calls, Zoom, and they just found that those moms did a lot better when they had someone talking to them who looked just like them. They started a Black professionals group for 30 and over, and how to address microaggressions, how to address what it looks like to be Black health professionals. And this all happened before COVID, but it was really handy when COVID came around because then we were all really isolated. But their outcomes, I asked about their outcomes because I'm an evaluator. I'm interested in that. They have a 95% full-term birth rate, which is incredible. 80 to 85% compliance. I wasn't quite sure what the compliance to, but no infant death after 2 years. Satisfaction in the range of 97% after 2 years. They are 80% grant funded and get 40 cents on every dollar from Medicaid. They do take private insurance. So sorry if that was long-winded because I was sort of reading my notes, but.
No worries. Thank you, Clara. Next, we'll have someone from Multicultural Dermatology, please.
I think I can provide a summary. We had a very productive discussion in regards to the efforts of the clinic, and we touched upon quite a few topics. We discussed the need for collaborations with other disciplines, from rheumatology to surgery, oncology, and also other institutions to galvanize not only the clinic development, but also the research initiatives and help and navigate the challenges that are involved in developing a program, a clinical program, at the same time that you are, supposed to be submitting grants and publishing on the findings that you have. We touched base on disparities in relation to the outcomes of cutaneous conditions in general. We highlighted the concerns that exist in diagnosing and treating properly conditions such as cutaneous melanoma, uveal melanoma, the presentation being the most common seen in individuals of darker skin color. And Dr. Crow basically, highlighted the fact that many times, individuals of darker skin are diagnosed at later stages and undergo more disfigurative surgical procedures due to the advanced nature of the disease when they're diagnosed. And other things like rashes, they're difficult to, there can be side effects of certain types of treatments that are more difficult to diagnose in individuals of darker skin. We discussed how to disseminate, not only the knowledge that he's accumulating, but also the knowledge that is being generated throughout, the field in regards to diagnosing and treating conditions in individuals of darker skin, and how to go about not only potentially developing a website that is easier for prospective patients and individuals to navigate, but also to potentially join podcasts and already venues are out there to make sure that the correct information is passed forward. Make sure medical students at medical schools in the area are aware of the existence of this clinic, so they can come and join and be exposed to the clinic and potentially be the next providers delivering this type of care. We also talked about involving patients and potentially making them become ambassadors for the cutaneous conditions that are seen at the clinic, and the potential great outcomes that can come out of being treated for professionals like Dr. Crow, who specialize in this area.
Thank you, Dr. Bruno. And our final report out, if we want to have a
Yes.
representative from that group. All right.
Yeah, I'll start and I'll open it up to everybody else that was in the group. If I miss anything. But I want to thank Dr. Ritter for taking such great notes for me to reference. There was a question I didn't see from who in the chat, but we started with discussion around the impact of microplastics. And one fact I want to draw up with it for everyone that shocked me was that there's estimates that we are consuming about a credit card worth of plastic every week. And that there have been studies finding microplastics, people undergoing heart surgery, finding it in plaques, arteries, blood, and that there needs to be more research on the impact of microplastics and their effects on us. We also talked about measuring the levels of chemicals in our blood and having that data to really drive EPA regulation is important. And we had discussion around forever chemicals that are detectable in individuals. We also talked about exposure through our foods and levels of chemicals. One example that Dr. Culicino gave us was a stick of butter at a store that had high levels of flame retardant found in it. We also talked about multifactorial effects and that there needs to be more research on the interactions between not just genetics and diet and access to care, but also systemic racism, stress, gender. And we had discussion around fragrances as well, that there's work being done right now to create a database on whenever we see fragrances on a label, what that includes. And I believe there was a Bloomberg article that'll be shared around that. But I also really liked, Jackie asked, what are some practical things that we can do while this research is ongoing, while the policy interventions are informed by that. And Justin gave us some tips of having air filters in your home, vacuuming, cleaning often, reducing your use of plastics, and especially not microwaving plastics, having a CO2 monitor in your house, filtering your water, and there's even someone that's just recently had an EPA grant that will be looking at removing gas stoves from homes. So I thought that was really interesting. And Mackenzie or Justin, am I missing anything that you think we should share with the group?
I think you got, and that was a great readout. Thanks, PJ.
Great.
All right, thank you so much, PJ. We will start our next 4x4 presentations. Dr. Beydoun, you may share your screen.
Yes, hello everyone. My name is May Beydoun, and I'm a senior associate scientist at the National Institute on Aging Intramural Research Program. I work at the Laboratory of Epidemiology and Population Sciences. So my presentation today will focus on plasma neurofilament light chain, or NFL, which is a non-specific marker of neuroaxonal damage and its association with various health outcomes among urban middle-aged individuals. So plasma NFL concentration was found to increase with age and also with neurodegeneration at varying rates. Its strong correlation with its cerebrospinal fluid counterparts makes it an appealing and non-invasive biomarker for various neurodegenerative diseases, including Alzheimer's disease. So we have previously demonstrated using data from the Healthy Aging and Neighborhoods of Diversity Across the Lifespan, or handles, that baseline and change in plasma NFL can influence cognitive performance trajectory over time in this sample of middle-aged urban adults. Obesity at midlife, defined by body mass index greater than 30, can on average increase the risk of Alzheimer's disease based on a meta-analysis by about 80% later in life. Obesity frequently clusters with various cardiometabolic risk factors, including elevated blood pressure and diabetes and dyslipidemia, for example, and also systemic inflammatory markers. Together, these phenotypes form what is known as the allostatic load. It is unclear whether BMI and the allostatic load independently predict the rate of increase in plasma NFL over time. So our main study that I'm presenting today uses longitudinal data from 608 participants in the Handle study, which included complete plasma NFL data from 3 consecutive waves of data. Using structural equations modeling and mixed effects linear regression models, we found that body mass index and total allostatic load score were associated with lower initial but faster increase in plasma NFL over time. The positive association between the body mass index and increase in NFL over time was significantly mediated through the allostatic load, but that relationship, that mediation, was only found among women. Overall, this association was mediated through the glycated hemoglobin level as shown in this figure. A neurofilament light chain is also linked to mortality in neurological disorders. Using data from Handles, we found that unlike among men, women exhibited a direct association between change in neurofilament light chain, so above versus below median, and all-cause mortality risk as shown on the right-hand side. As you can see here, among men, we didn't find any difference between above and below median. So in this next analysis, we used data from the neuroimaging substudy known as Handle scan, specifically on 180 participants with complete data on NFL at 2 consecutive visits. We found that baseline plasma NFL measured 5 to 6 years prior to brain scan was consistently associated with larger white matter lesion volume, or what is known as white matter hyperintensities. The brain image shows the regions most affected, which include the posterior limb of the internal capsule, shown in yellow here. And this is a region that was associated with executive function, domain of cognitive performance. So these findings were mainly detected among women, and as you can see in the table on the left-hand side, there is an interaction by sex showing that there is heterogeneity by sex. In contrast, follow-up plasma NFL, which is measured more proximally to the brain scan, about 1 to 2 years, was linked to reduced hippocampal volume, mainly among men. And as you know, a hippocampus is related to verbal memory. Both large white matter lesion volume and reduced hippocampal volumes are early markers of neurodegeneration at midlife that can predict future dementia risk. So in conclusion, based on several studies that made use of the Handles cohort, we showed that dynamic changes and levels of NFL were associated with several aging-related phenotypes in a sex-specific manner. Thank you very much.
Thank you, Dr. Baydoun.
Thank you.
All right, Claire, you're up.
Okay, hi everyone. Let me share my slides real quick. Give me 1 second. Okay, so I am happy to be here. Thanks for the invite. And I'm going to share with you a very high-level view of the work that I do in the area of women's health, reproductive health, and disability, and primarily physical disability from any cause. And the ultimate goal of the research, I'm going to tell you a little bit about that in a minute, is really to accelerate the pace of change toward reproductive health equity, which is not optimal, but we really need to advance both the science and solutions and interventions. And there are about estimated 8 million women, adolescents and girls with, 8 million women who are of childbearing age. And every year, tens of thousands of young girls with disabilities will enter into about 40 years of managing their reproductive health, ranging from periods and pregnancy and through menopause. We know people with disabilities are living longer, and and they need high quality reproductive health care like anyone else. It could be a little more complicated, but certainly the needs are there. So a really big picture view of some of the pressures that come to bear on this aspect of health for these women. There are healthcare system barriers, and these are things like inaccessible rooms, being able to get on and off exam tables and so forth. Their health can often be much more complicated depending on the cause of disability. There is a lot of gaps in information that is relevant to support both healthcare providers as well as women themselves for making all sorts of decisions. A lot of the work we've done is in the area of pregnancy decision-making, but this can be how to manage periods, what products to use, sexual health and function, and there's a range of aspects of health with very limited information about how to manage that optimally. And certainly the effects of disability bias and discrimination. And these are things like stigma. And all of these come together that can make a very challenging interface to manage reproductive health in the context of physical disability. So this statement is from the WHO and the UN about what are the components of optimal reproductive health. And what I want to emphasize in this statement is the words informed, empowered, and enabled. And these are things that I'm gonna tell you about how they are reflected in the work that we've done. And it is really to make informed decisions, undergo testing, the whole gamut, about all aspects of reproductive health. So when I say reproductive health, I mean very, very broadly. So this is a model of a conceptual framework, and the excuse me, the references below. And this came out of work supported by the NIH to really understand the concerns and the issues around reproductive health broadly of a population of women with physical disabilities, again, irrespective of reason, of cause. And so there are three areas that I want to just very briefly talk to you about related to these concepts of informed, empowered, and enabled. And the first one is knowledge. And I mentioned this a little bit before. So this idea of being informed is best represented in this framework about knowledge. And you can see, the thing I should mention is, you can see there are these connection points. And just one glance at this model will tell you this is complicated and a lot of things are connected. I'm already out of time, it's 4 minutes. So knowledge about reproductive health, very limited for this population. Another key thing in terms of being empowered is self-advocacy and identity play a very important role. And you can see it's connected to many things in advocating for oneself that is also related to an identity as a woman with a disability. And the last area are specific reproductive health issues that are related to gaps in knowledge, the need for self-advocacy to overcome barriers in the environment and attitudes and so forth. And all to say, because I'm already out of time, is all of these things are intimately connected. They're not simple, but they're very important to address. And that is the goal of our research. And that's it. Thank you.
Thank you. And now we'll have the team from the University of North Dakota. Dr. Williams.
Yes. Hey, everyone. Thank you so much for this opportunity. With me are two students who are helping lead some of this work as well. So we're very excited to be able to share this with everyone today. There we go. All right, thank you so much. We're from the Department of Population Health and the Department of Indigenous Health at the University of North Dakota. And the three studies we'll be briefly mentioning today, we're really looking at trying to identify intervention points for perinatal health. And really the goal of this work is to improve maternal mortality through some targeted perinatal health interventions. We are working to address persistent disparities in American Indian populations, thinking through long-term public health outcomes through strategic interventions. And all of the work that we are talking today about is work done using the North Dakota Pregnancy Risk Assessment Monitoring System, or PRAMS. This is data that looks at maternal behaviors, attitudes, experiences, etc. And for our work, it's a representative sample using stratified systematic random sampling, and American Indian women are oversampled in the state of North Dakota. They try to get 100% of all American Indian births in the data. Our first study looked at whether or not telehealth use was able to address disparities in prenatal care. For a long time, we've known that North Dakota has really persistent racial disparities in prenatal care, with American Indian women having about twofold higher rate of not getting or getting late prenatal care compared to white women in the state. We've seen an alternative modalities be able to address some of these issues in various other contexts around the country and around the world. And the COVID data allowed us to take a look at whether or not telehealth would be able to help us address this issue. But in short, when we modeled our data, the upper estimates here show us the unadjusted for telehealth results. We still see about a twofold higher rate for American Indian women in not getting early prenatal care or getting that late care. And then once we're able to adjust for telehealth, so it's essentially, did you use any type of telehealth or not to obtain your care, the estimates didn't really move much. So what we're seeing is that telehealth doesn't seem to work in its current format, and that infrastructure investment and culturally safe care is likely needed to help improve access for American Indian populations.
Hi, so my name is Anna, and for this study, we were interested in how COVID impacted the association between marital status and breastfeeding and the potential modifying effects of race, ethnicity, income, and education. Previous studies suggest that marriage promotes breastfeeding through social, emotional, and financial supports. However, during COVID, relationships were strained, especially among low-income and racial minority populations, who were also otherwise disproportionately impacted. In our study prior to the pandemic, marital status was a stronger predictor of breastfeeding duration among low socioeconomic status women. However, we found that this population and American Indian women lost the benefit of marriage during COVID, whereas for white high-income women, the benefit increased. More health-promoting supports are needed for low-income and racially minoritized populations during and after public health crises.
In this study, we investigated interpersonal violence partially mediates the association between adverse childhood experiences and postpartum depression. Research shows that both adverse childhood experiences and interpersonal violence increase the risk of postpartum depression. Adverse childhood experiences can serve as predictor of interpersonal violence. However, there is a notable gap in understanding how interpersonal violence mediate the relationships between adverse childhood experiences and postpartum depression, particularly in rural population. Interpersonal violence appears to contribute approximately 10% to the association between adverse childhood experiences and postpartum depression. To address this gap, additional screening for social drivers like interpersonal violence and adverse childhood experiences is pinpoint. Effective intervention points and also comprehensive intervention are needed to tackle the underlying causes of adverse childhood experiences and interpersonal.
Thank you so much.
Thank you. And Libby McGraw.
Good morning, everyone. Looking forward to this time together. Let me go ahead and get my slides pulled up. Okay. All right. Good morning again. Thank you for welcoming me into this space. I won't actually be presenting necessarily on research findings that I've conducted, but rather some population health tools and data that might be helpful with informing women's health equity, particularly here in Northeast Ohio. I'm with the Center for Health Affairs in Cleveland. And again, I'm going to be talking a little bit more specifically about women's health and health disparity data that's available through our publicly available data platform, healthyaneo.org. Our mission is to improve and support community health across the 9-county region by providing stakeholders with access to vetted population health data and resources through a publicly available platform. We do have about 300 health and quality of life, social determinants, and various other health indicators that are available at various geographic levels. We serve a regional footprint here in Northeast Ohio that covers 9 counties, so Ashland County, Ashtabula County, Cuyahoga, Geauga, Lake Lorraine, Medina, Portage, and Summit counties. And most of the data that we maintain is through state and national level sources, but we do also have some locally maintained data indicators as well. And so it can be a really great resource for tracking women's health data locally and again across the region. It's very effective. The platform is very effective in understanding and exploring community needs, prioritizing needs, visualizing data, and then all of the data can be very helpful for conducting needs assessments, grant applications, and of course, research or other presentations. The first tool that I do want to feature with you all today is our demographics dashboard. This is a really helpful tool for describing female populations, and it can provide you access to about 250 demographic elements from a source called Claritas, which is a nationwide research market group. And so that's where this data comes from. It is updated annually, so the information that we're currently housing on our website is updated for 2023, and so we'll have 2024 data soon. And you can see here up in the top left that we do have a handful of female specific demographic indicators. So for example, female population by age group can be viewed. You can also see educational attainment in the female population. And the data that's on this dashboard is available regionally at the state level, county level, and also down to the zip code level. So you can be very specific with looking at identifying and describing your female population here in the area. What's really great about these visualizations is that they can be downloaded and utilized as needed. So if you needed them for a report, for a justification, these could be very, very effective for those purposes. And the next item I want to feature is just our general health data that we have in terms of women's health. So a lot of the site has various different topics, but we do have quite a few women-specific health data. You can view a lot of these in various formats, but they can be very helpful for understanding comparisons. These visualizations that we're featuring here are maps and also indicator detail cards that can be downloaded and exported as needed. And another way that you could view data on the platform, and maybe a great way to bring together a lot of women's health information, would be to create a custom dashboard, which would bring together all the women's health data for a specific area, geography in our region. So here we've pulled together some data for Cuyahoga County in relation to women's health, and you can see that there are multiple comparisons to other US counties, Ohio counties. We have values and trends that are also listed here. So it can be a really effective tool, again, in just getting a really good understanding of women's health data indicators here in Northeast Ohio. And the last slide that I'll feature for today is our disparities information. So this is a really great feature to highlight health disparities in women's health across Northeast Ohio. It can be used to view all of the data indicators that we have that include breakout data, and that would include topics such as race and ethnicity, age, and gender for a specific indicator. So in this example on this slide, we are looking at gestational diabetes in Cuyahoga County, and this data comes from the Ohio Pregnancy Assessment Survey. And for this data indicator, we do have breakout data. You can see here on the left by income for gestational diabetes. And then just because it didn't all fit under here, we broke it out too, just to show that we also have gestational diabetes information based on race, ethnicity, insurance type, and even maternal age. So this is a really great tool and a really great feature for looking at some of that disparity information, specifically for our women's health data indicators. If we were live on the site, it's a very intuitive platform too, and it would actually show red or green to show whether breakout values were performing significantly better or worse than the overall value. So just another really great way to visualize and utilize some of that information for research purposes. And with that, I will leave you with my contact information and a call to action to visit healthyneo.org for more information. Thank you so much.
Thank you, Libby. And now we will head into our second and final breakout sessions. The rooms are now open. And if this is your first time joining us, if you are a 4x4 presenter, please join the room that aligns with your topic. And if you are a participant, please join the room that aligns with the topic that interests you most. Thank you.
Yeah.
This Okay, once everybody makes it back here, we'll start our report out for the second half. It looks like everyone's trickling in. Can we start with the representative from Dr. Baydown's group to give us a report?
Absolutely. So we had great talk. We were definitely bouncing all over the place with different types of topics within the chat. So it was kind of fun to kind of see the progression of everything. So, talking a lot where we were talking about just overall the disparities with men and women based off of like our metabolic conditions that we may have. So very crazy to think that just because you're a woman, like you may be more, predisposed to certain conditions. And then too, we kind of got into like COVID and dementia. So we're kind of talking about like, different things with COVID. I know we were talking about brain fog and trying to see like, trying to see Dr. Baydoun's thoughts on how that's a precursor with dementia from that brain fog with COVID. So then, and even too, just even talking about the COVID vaccine with like the neurological disorders, and how people in their early 20s, 30s, 40s aren't getting the COVID vaccine because they're so nervous of those different disorders. And then rounded out the conversation a lot with just going overall, just like food access, obesity is definitely something that we were definitely talking about within that, about how if you give women, which Dr. Baydoun was saying this, which is really interesting, if you give women the money, it gives them the more opportunity to make better choices and compared to men. So it's kind of interesting how women, if they have more money, they'll go and get the better food, the organics, or, just the healthier lifestyle, versus men aren't opted to do that as much. So it's a really interesting fact that she shared with us. And overall, just, hoping that some policies come from, especially with Dr. Baydoun doing all of her research, to get some policies put in place where we can have more accessible food so that we can really, help a lot of these different comorbidities and different conditions out there to really make a healthier America, because life expectancies are just, not ideal at this point. So one of the people in the breakout room actually was talking about how life expectancy has actually gone down 5 years with African Americans since 2016. So, being able to put in policies to have these researchers do that work to get that so that our life expectancies can go back up. And so we can just, be a better country and overall world. So.
Nice. Thank you so much. We can move to our small group. Dr. Kalbakjian, I'm sorry, I'm probably mispronouncing.
Oh, that's okay. That's okay.
Go ahead if you want to give the summary.
So I'm gonna summarize some of the things that we talked about, and then other people there can certainly jump in. So one of the questions was around how, addressing gaps in knowledge. How do we rectify that? And the one thing I shared is that a lot of women feel like they get caught between, they know who they are, they know their bodies, they know how they work, they need healthcare providers to help them make good decisions and educate them, and they're not prepared. So nobody's happy, and it is this challenging interface between unmet needs of education and how that information flows, which also leads into the importance of relationships with healthcare providers, which is true for everybody, but in particular to be able to communicate openly, wanting healthcare providers to be curious. Often healthcare providers are nervous if they don't really understand the disabling elements and so forth. We talked a bit about sex and how pretty much nobody's comfortable talking about it. The healthcare providers, as well as the women themselves, they often will want to talk about sex, but don't want to bring it up. And healthcare providers don't always want to bring it up too, or feel like it's just kind of outside the scope of their expertise, and really connecting with people like Rachel who have expertise in this and can really support healthcare providers and women. Then one of the other things we talked about was the importance, I think I skipped over this, relationships with healthcare providers, which can either be comfort and joy or avoidance and anger, unfortunately. And then the last things we talked about were how to use this conceptual framework that I presented as really the foundation for interventions. I shared that the field itself has been wringing its hands for about 40 years, but not actually doing a lot about the problem. A little bit stuck in understanding and not acting, because we know these are longstanding problems. So I have a ton of ideas, but things like interventions to support young women with disabilities before their first pelvic exam. There is a product to assist women in inserting tampons who have limited hand function, which really can give a lot of freedom to women who want to use those products. I'd love to develop self-advocacy interventions to support women of all ages and types to overcome a lot of these barriers. We talked a bit about ideas for peer navigators to work with people, women with disabilities, and navigating some of these things like a pregnancy and so forth. And those, I think, are the highlights. If I missed anything, the other people in the group can jump in.
Oh, that was great. Can we move to the group with on the Indigenous women's health?
Yes, we had a wonderful discussion. Andrew and Anna really brainstormed and explained a lot of questions that we had. One of the points that came up was the dangerous generalization of different Native Indigenous groups and the difficulties that there are when you are working with different tribes and getting information that is specific to different tribes, and how not all tribes have IRB approval for at the state of Dakota for you to extract information and gather information. Issues in regards to differences in access to healthcare. There's a lot of heterogeneity when it comes down to access to healthcare and geographical disparities, throughout the country, throughout North and South Dakota as well. There are several areas. There are maternal health deserts in those states, and how the initiatives are ongoing right now from IHS services are also to a certain extent linked to the fact that the payer for most of the women in reproductive ages is really Medicaid. So it creates even more complexities when it comes down to different states and what it allows or regulates, differently. We talked about telehealth access and the structural barriers to telehealth medicine, from internet access to cell phone services, physical space to have a private phone call, even in multicultural homes, which is something we don't think about. But this is something that can hinder the delivery of telehealth services to decrease disparities. We asked Andrew to come up with top 2 priorities for Indigenous women's health, and he named access to care, how to close the gaps in delivering care, and utilizing community health centers to provide high quality care, assessing the levels of care that are not accessible in those areas, and making sure there's communication and referral patterns or pathways that are very clear and established to take those women to higher levels of care when necessary. And also how it's important for IHS birthing facilities to start to accommodate for cultural specific demands, of the population they serve, such as not having smoke detectors in areas where the birthing is taking place because, the family wants to come, and there are certain specifics of the celebration that may involve smoke. It was really emphasized the need for both Anna and Andrew hammered on the idea on how important it is when you start working with different tribes to make themselves useful and understand what the challenges are and how they can help and close the gaps instead of coming and offering what specifically what they will do. More so listen. Anna used the term worker bee. She's a worker bee. She puts herself out there, and starts doing work from physical work, helping the different groups, but also, Andrew bringing up the idea that you have to understand what is it that you need. You need to understand what Medicaid is tracking and how to perform better so you can have better billing for whatever is it that you're offering and so forth. Finally, I think we talked about the negative economic impact of COVID on those populations and how that, really created some challenges in marriages for some groups, in the U.S. rather than others, and how it is difficult sometimes even to report interpersonal violence for populations such as American Indigenous and Native women. So, for instance, they are fearful of reporting interpersonal violence, and that they fear that they can lose their children if that type of violence is reported. So you see discrepancies sometimes in reporting of interpersonal violence. So really, really interesting, informative. I was very excited about the session. I don't know if Anna, Andrew, do you want to add anything?
No, I think that was a really good summary. Thank you so much for that. Yeah, we're just really excited to be able to come and share this work. So I had a great time.
Thank you so much, everyone. Yeah.
Great. And the last group is from Libby McGraw's Wealth and Women's Health Equity Disparities using the dashboard.
Yeah, I can give a summary and Libby can catch anything I might miss. I think our first thing to highlight is for everyone to go to healthyneo.org and to bookmark that website if you haven't already used it in your work, and especially if you're focused in the 9 counties that they curate data around. But we had a lot of discussion around how that tool is used for a wide range of use cases, grant applications, research, just general community knowledge about a specific area. A new maternal and infant mortality dashboard was recently created, which is an example of how the Healthy NEO team not just centralizes a lot of different disparate data sources, but curates that based on what our region needs. So that's another thing to highlight for this group is if you ever have any data needs, the Healthy NEO group is wants to partner and work with you all. And we talked about how it's a free and publicly accessible data source. So anytime you all are working on projects that it might be beneficial to have information publicly available, that is something that they can work with you on. And one example is the county health improvement plan. I believe it was one county that's currently using it to track progress. And we had some discussion around just the time and cost savings that a resource like this provides our region, especially for smaller organizations. And I thought it was really interesting. We had someone in our group that was from upstate New York and shared a lot about how maybe they wish they had a resource like this, and it left a lot of data collection up to them. So I think it's a resource that I know I just recently learned about it. So it's something for us all to maybe keep in mind in our work and in our research. And I think the last thing I'll add, if you're a professor on this call, there's been a couple that have included it in their syllabus for students as a resource for projects. So that might be one way to raise awareness about it. And we also had some discussion about greater partnerships with the universities. So I think this is definitely the perfect forum for that discussion. But Libby or Mackenzie, did I miss anything?
Nothing from me, PJ, but I did go ahead and add that. Thanks for mentioning our new maternal and infant health dashboard. I did add a link to that for the chat if anybody is interested in viewing that. And then, yes, please feel free to contact our team if you have questions. But nope, nothing else that I had for you, PJ. Thanks.
Awesome. Well, I'm going to try to synthesize all of this. I think, there's been so many wonderful presentations. I love these bite-sized 4x4s and the talks that have developed from them. I think the interesting thing about health inequities is that, there are some things that we are aware of, like we are aware that there are health inequities for women of color in Cleveland, and we still need to keep looking into that, and so happy that we're seeing people working on that. But then there are also inequities that we're not aware of. And going through topics like skin to the environment to women with disabilities and their need for sexual health services and reproductive health services, all of these things that just kind of get missed is exactly why this meeting was put together, so that all of these intelligent people here can put their heads together and start thinking through, what is the next step for research? What is the next step for a public health intervention to help translate that research into the real world? I'm so happy to see so many students that were here participating, so you can see public health sort of in action, and to see so many, incredible researchers who are bringing those students along and pushing the envelope and bringing to light those areas of inequities that are not otherwise being addressed. So just to kind of try to summarize throughout the day, from our breakout session this morning, going through the issues that women of color are dealing with in Cleveland, but seeing that there are organizations really addressing them through an out-of-the-box sort of approach, improving infant mortality, improving satisfaction, and taking care of both the mom and the baby. Looking at not only skin, but also hair loss, and looking at what is needed for women who are otherwise not getting attention, or skin conditions that are being not noticed. Looking at the microplastics, I was shocked. What I learned today? I'll probably not forget that we consume a credit card amount of plastic every week, which, oh my goodness, is just part of the larger problem with our plastics and chemicals in our environment, and the way that could lead towards cancer and other health disparities that are already existing. We looked through multiple different aspects of interventions for women with disabilities, and really just shed light on the need for paying attention to the healthcare needs and the research needs for women with disabilities. We talked through Indigenous women's health and the multiple aspects. I really appreciated having the 3 different students present on that and kind of show us the different projects that are happening there. And also, I just love to see the collaboration between all of these institutions and learning from one another. Michigan's not that far away, and yet sometimes it's hard to know what's happening just a couple of hours away. And then the dashboard, the disparities dashboard, and thank you for the updated link. If anybody didn't see it, it's in the chat. That is extremely helpful for research, for knowledge building, and to keep ourselves up to date on the data. Forgive me if I'm forgetting everything, but or anything, but I feel like that it's just in general, there's so much that came up. And I hope that we can find ways to collaborate with one another from this. We don't want this conversation to end here. We want this to be a launching point. The CTSC is, you know, exactly that. It's a collaboration, and we want to continue promoting that sort of work and pushing the science forward to improve care for women, especially with all these health inequities. Please take some time to click this link in the chat that Jaleese posted there to complete your evaluation before you leave, because once you leave the Zoom, that link will disappear. I want to say a special thank you to Jaleese Thomas for organizing this, for Zina Hemsed for all of the assistance that she does in the office as well, to Dr. McComsey, who runs the CTSC here in Cleveland, and to all of our scribes and moderators. You made us take this large information and make sense of it all. And I feel like this morning has been extremely fruitful. It was just a very short sort of morning to get this much information out. Now my head is just kind of pinging with all these different ideas, and I'm sure I'm not alone there. So thank you all for your time, and I hope that we'll do another one of these next year. And have a good rest of your day. Don't forget the evaluation.
Thank you.
Thanks.